So, folks, I've started recording because one of the things that we said we would do with this webinar today is we would put it up on the cloud so that people can kind of see it. And not that I imagine there's going to be that much wisdom from my mouth over the next 25 minutes, but for anybody who's feeling brave and wants to log into the recording, it will be up and it will be online for them to watch afterwards. So look, thank you all for taking the time. For any of you who've hosted a large group like this before, you know it's super surreal from my point of view. I can see all 32 of you right now, or almost all of you, but I can't hear a thing because you're all muted. So I'm going to try and crack a few jokes and try to be entertaining. And I have no idea if this is the most boring, disastrous experience you're ever going to have. There's a few folk I can see right now. I have Tara and Dougie in view, and if they look like they're walking out to the loo, I know I'm making a really big mistake, and I should do something with my jokes. So thanks for calling in. Many of you are from Lucina and from Clonmara, but a couple of you are also from a couple of other services that have expressed an interest. So there's a few of you from Highfield Health, and there's a few of you from St. John of God Hospital. So you're all very welcome to our short webinar today. In these surreal and strange times, I guess I, for one, am glad there was no big notification at the weekend. So the world is the same this Monday as it was last Friday. And that's no harm with the amount of changes we've had coming our way. Today is the first of two short webinars, and they're designed to be two sides of the same coin. My focus today with you is just to come and talk about video conferencing at a very high level. And then tomorrow, my colleague Murren McNulty will talk more specifically about the delivery of video conferencing in a mental health kind of setting. So I'm calling today Video Conferencing 101. And for those of you who don't know me, I'm a psychologist, and you're probably wondering why the hell I think I know something about this. Well, it's kind of a little bit of an inside joke, because the truth is I am absolutely no expert on video communications. Anybody who's ever worked with me for any period of time knows that if technology can go wrong, it's probably going to go wrong for me. And in many ways, I'm probably the last person in the world who should be delivering this stuff. But there's a little kind of quirk in my history, which is why I'm sitting here. For the last couple of years, I worked for one of the big tech companies in Dublin, and one of the global tech companies. And in that context, I spent a lot of those 2 years using video conferencing technology. Almost everything we did was by video conferencing. You'd nearly not go to another floor to meet somebody in person. Instead, you'd kind of log in and do a video conference. So what's kind of funny in that setting is I was the most embarrassingly tech illiterate person. People would largely point at me and laugh because I knew so little about technology. So they were, engineers and doing this stuff, and I would struggle with kind of logging in. So please take me with a pinch of salt today. But I guess I did learn something about the basics of making video conferencing work by relying on it for such a long period of time. But it also took me a while to get used to it. So if this is all completely new and novel and intimidating to you, welcome to the club. I wish I had some photographs of me in my first couple of weeks in this tech company, standing lost in a sea of engineers, not knowing how to turn something on, not knowing where to go. There are some friends of mine in there who still talk about the fact they had never seen somebody so lost at work. So if you're feeling lost right now, I totally know how this sounds. There's one other kind of reason why I've kind of put myself in this role. I have actually done a fair amount of therapy via video conferencing over the last 10 years. And there's a bit of a context to how that happened. After our last big economic crisis, the one that happened 12 years ago that we thought was the big one, I had a small private practice. I've always had a very small private practice. And I had a number of clients who moved to parts of the world where English wasn't the spoken language. And they moved during the course of their therapy and were not able to find therapists who spoke English in their new locations. So while I wasn't kind of looking to find an online or a video conferencing business to support people in the absence of alternatives, I kind of stepped in to try and do some work initially in the short term to kind of cover the gap. And what was really interesting is that some of these became therapy relationships that went on for months, or in some shape, in some cases, even for years. And I was surprised by the potential for working this way with clients, including in some kind of pretty serious situations. There was a suicidal crisis that was managed over a long period of time with video conferencing, connecting with local clinicians, and some various kind of difficulties that kind of happened. So I suppose, even before I mention the fact that there is a lot of data to support video conferencing for mental health intervention, and there is a lot of data to support mental health interventions over video conferencing, my own lived experience was this stuff kind of works. It's more possible than I ever would have imagined. I didn't imagine that we would be sitting here in these bizarre circumstances looking to move our services very, very quickly onto kind of video conferencing platforms. And I guess in an ideal world, we would have weeks and even months to do the due diligence with this. At the moment, I think a lot of us are trying to build the airplane as we fly when it comes to video conferencing. We're kind of having to lift off and do some of this stuff. And I think with each week and each day even, we're learning some new things to add into the mix. So this is not a complete picture. And I don't think any of us would have chosen to kind of do it this way. But here we are in the situation in which we kind of find ourselves. So here's my overall aim for the short timer together today. The big aim is I would like to kind of spare you some of the painful learning that I had when trying to get video conferencing kind of off the ground in my work life, and share some stuff that I learned so you don't have to do it the hard way. So I think maybe the single most important thing I'm going to ask you to do if this video conferencing stuff is new is be brave. It's weird and unusual, but I think there is a pressure on us to be brave in stepping into this space. And I guess one of the things I might say to you is to say this. I think that mindset really matters in terms of doing kind of video conferencing work. If we approach this kind of with a, just because we have to, and this is really crap, but we really wouldn't do it any other way, I think that we'll kind of communicate that to our clients and our patients, that we're kind of coming at this as very much, a limited way of interacting. So I think that if we can dive in and say, look, there's a lot of evidence for this. There's 10 years of doing video conferencing in parts of the world. I mean, places like Australia, for example, you could find yourself a time zone away from your nearest mental health clinician if you were based in kind of an agricultural or a mining setting. So 10 years ago, Australia started using video conferencing as a way of doing general practice, psychiatry, psychotherapy. So see if you can bring your mindset with you and say, look, you may not have chosen it, but this stuff can work. And maybe we might even learn something along the way. Beyond all of that, let's maybe kind of dive in. Now, this is hopefully going to make some of you laugh a little bit. My background is as a DBT therapist, and anybody here on this call who is a DBT trained therapist knows that we use acronyms for everything. Acronyms are how we teach our skills and how we help clients remember some of the ideas we want to share. So when I was thinking about this last weekend, I came up with a little acronym for 6 particular steps in doing video conferencing successfully. And I'm calling it 3 by PETS because there's 3 P's, there's an E, there's a T, and there's an S. And I'm going to just quickly zip through these. And it's going to sound kind of crazy, but I'm not going to do them in order. I'm actually going to jump around because for various reasons, it makes more sense to do it this way. So I'm going to start with technology. And in terms of technology, this is such an easy thing for us to forget, but it's really important. Make sure that your batteries are charged up in advance on whatever devices you're going to use for a video conferencing call. And also ask your clients to charge up your batteries. I've been doing some calls last week, and on 2 occasions, clients' batteries died mid-call. So I failed myself in sending out a message in advance to clients and saying, hey, just make sure you charge up before we meet. It just helps the whole thing be a less insanity-inducing experience. The other thing is to ask you to just accept that your technology is going to fail. So with the best made plans when it comes to video conferencing, stuff goes wrong. Video screens won't work, the sound goes out, the call drops. These are all possibilities. So in terms of doing our video conferencing with our patients, I think having a backup plan is absolutely crucial. The simple backup plan I would put to you is make sure that you have your patient's phone number to hand, and let your patient know that if the call goes wrong, if something falls apart, the technology becomes super frustrating, it's really simple. It doesn't have to be a big ordeal. Just end the call and then phone your client the old-fashioned way, and make sure that your kind of patient knows this in advance. If you are using phones, make sure that they're propped up. And the reason I kind of say this is how many of us know the experience of the shaky camera. And once you're holding any form of a smartphone or even a tablet, this is what happens. So what we're asking our clients to do, and what we actually do ourselves, is if you're using a phone, make sure it's propped up. But the one thing that you're kind of not doing is holding the camera throughout the call. So those are the three kind of technology things to talk about. Let's talk about the picture itself. In terms of the picture, where possible, don't use phones. And the main reason to not use phones is that the image itself is too small. We want to try and recreate the experience of sitting with somebody in person as much as we can. So using a monitor and using a tablet kind of more closely mirrors the real experience. And of course, this won't be possible for all of our patients. For some of our patients, it will be a miracle to get them up using a smartphone for this stuff. And getting a laptop or a desktop or a tablet in the picture will be too complicated. So I'd say hold this lightly. If it's possible, great. If it's not possible, just let it go. But where possible, let's try and get, and encouraging your client, of course, to do all the same stuff. In terms of positioning, this is important. Try to use a center shot for because people come in all kinds of interesting ways. What I've definitely noticed is that loads of us come in this way on video calls. We do the under the chin view. We're not really thinking about it. We pluck up a device and basically we're showing off our nostrils to our clients. And our clients are doing the same to ourselves. So spending a bit of time in positioning cameras and playing with this so that you're getting a kind of straight on view can make a world of difference. Also, for yourselves, firstly, think about your setting. Think about what's behind you. I mean, I very deliberately have called in the space that I'm doing some therapy at the moment. So I've got some of the real cliched stuff. I've got some books behind me. I've got my little lamp. I actually have candles, which is like, an embarrassing cliche for a therapist to be kind of showing you. I have my little plant. But I'm trying to communicate, hey, this is a place where we kind of sit back and we think. So set up your environment so it kind of is considered in a way that kind of looks a little bit like the places you might normally see a client. And ask them to think about their environment the same way. Now, the things that are most important for your client in their environment is thinking about the chair, thinking about their comfort in sitting with you for what's going to be longer than just a short call. I mean, definitely making sure that it's some form of kind of environment that was that doesn't have a whole heap of background noise. And we'll talk about privacy in a few minutes, but I think these things are all kind of connected. Crucial to this, I think, is if you as a therapist are kind of sitting with a wall behind you, it kind of looks like a mugshot. Now that's not me, it's another ginger, but it's not me. But when you've got a big white wall behind you, it just kind of has this kind of effect. And for your clients, in terms of thinking about their environment, there's one key question to ask every time you start a call: where are the tissues? And get your client to get up and get a tissue box or get some tissues before you start the meeting. Because it's the business that we do. We have conversations about difficult things, and it makes sense that you would ensure that some kind of tissues are at hand. Just kind of sticking with this idea of the picture itself. Think about lighting. If you have a source of light behind you, this is what it's going to look like when you call in. So when you're kind of orientating yourself in the room, you want a source of light in front of you or to the side of you. but lighting behind you won't work. And of course, if there's too much bright light in your face too, the whole thing looks like an interrogation. So give it a little bit of thought in how this kind of looks, and avoid this. I think a lot of us have a natural tendency to kind of lean right in and stick our face into the camera that we're calling from. So avoid the close-up and instead really think about being visible from the waist up. This is the kind of optimal kind of setup for a video call. And there's a couple of really important reasons, in fact, why we go for this kind of setup, because it allows us to communicate with our bodies. We know that somewhere between 90% of communication comes from gesture, expression, and posture. We want to ensure particularly that our hands are available. If you're going to think about my setup here, I've got a little iPad in one hand right now where I've got a few reminders, but it's deliberate that my hands are visible, because many of you right now, I can see you from the head up when I'm looking across my screen, which means I've lost a whole bunch of ways of understanding what your experience is right now. And equally, you want to get your clients showing you more than just their face. When you're trying to understand how a client is doing, if you've just got access to a patient's face, you're missing a whole bunch of communication that's coming to you in terms of how that meeting is going. So all of this is kind of pointing to the idea that to make video conferencing work, you're going to have to spend a bit of time with each of your patients, coaching them on how to best set up the call. I'll talk about this before we finish, but for me, it's a 10 or 15 minute kind of meeting that's specifically scheduled to do some of the coaching. You call in, you check the tech, but also then you give a bit of feedback to your patient on how they're setting up their camera, making sure they've got everything they need in the room, and really, really encouraging to understand, helping your patient understand why it's important for you to be able to see all of their kind of, gestures, and to see their hands, and to help you better understand what they're communicating. So going back to our 3x-PETs, we've talked about technology and we've talked about picture. If we were to talk about posture for a few minutes, here's the big message. The message is to sit back. Again, there's that kind of tendency to kind of lean in, and straight away, kind of you're communicating this kind of intensity to your client. It's taking away that kind of space that we have when we meet with our patients to kind of sit back and listen to what they have to say, and creating a little bit of space. But beyond the communication benefits of sitting back, many of us who've tried some video conferencing have noticed that video conferencing, it's kind of intense. Like when you meet a client this way, it sometimes feels much more tiring and produces kind of headaches that may not happen if you were sitting in a room. And one of the things I think that happens for a lot of people is, firstly, they spend a lot of their meetings kind of hunched in, staring at the screen like this. Isn't any surprise that you end up feeling you've got a headache and you're exhausted afterwards. So really thinking about the chair that you're in, sitting back in that chair, and just coaching yourself, I guess, to kind of sit back. But there's other benefits to sitting back. There's the communication benefit, but there's also actually some of the neuroregulatory benefits that come when we sit back. We know that kind of leaning back and kind of breathing deeply, this is stuff that switches on parasympathetic responses. This kind of helps us feel curious and open rather than kind of switched on and tense. It's a way to kind of trick our minds by using our body to kind of calm down. And again, because of the weirdness of all this video conferencing, you've learned over years of clinical practice how to keep yourself regulated in the room with your patients. But either sitting in your office, or many of us will be doing some of our work from home going forward, these are strange and unusual places for us to work. So we've really got to kind of go back to basics in terms of regulating ourselves and staying composed and calm during our meetings. So in fact, I'm going to smuggle in a little skill that comes from radically open dialectical behavior therapy, which is a type of DBT for people who've over-controlled emotions. And the developer of this, Tom Lynch, has this incredibly neat little 4-step maneuver to help kind of tune down feelings of frustration by switching on parasympathetic nervous responses. And the 3 steps plus 1 are, firstly, lean back, which is exactly what we're describing. We want to signal to your brain with your body that you're actually safe. And after leaning back, we want that deep breath, because we want to basically push on your vagus nerve, which helps switch on your vagal system, which helps you kind of feel safe and open. Then we want to think about the closed-mouthed smile. And again, there's a whole bunch of weird research that particularly comes out of kind of Buddhist circles on the kind of value of using the closed-mouthed smile rather than the open smile. And the fourth step in kind of just disarming your body is actually to raise or to wag your eyebrows. Even if you all do it with me right now, I'm switching on my camera view. If everybody just sitting where you are, sits back, takes a deep breath, does a closed-mouthed smile, and I'm looking at you, and you raise your eyebrows. You're doing all this not for your client and not for each other. You're doing this to try and disarm your body. And I'm actually going to stop for a moment and just ask, what are people's experience when you've tried that? Does anybody want to dive in? So leaning back, taking a deep breath, half smile, and wagging those eyebrows. What's happened? Somebody help me out. I'm sitting in complete silence.
I want to make you suffer, Jim.
No, you're helping me, Ronan. Thanks so much.
It's pretty cool, but I've just realized how uncomfortable this chair is.
Do you know what? Looking at your chair, it reminds me of a dark version of that chair that Graham Norton uses, the red chair, and then people fall backwards afterwards. I mean, it's a pretty full on, because that's a gaming chair, you said, yeah?
Yeah, it's a gaming chair. Yeah, I got my thumbs ready.
It's intended for something a little different, but no, thanks. So you did the 3+1, because I think we can get so tense with our bodies kind of during doing some of these meetings. It's really to remind ourselves, disarm that feeling of tension inside. Anybody else give it a try? Anybody want to give some feedback?
I think it might be something to do with James's work, that it's you act happy and you become happy, and I think that's probably where it's maybe based, is it? Well, yeah, that's where the Buddhist idea of smiling and
well, I guess there's a lot of kind of real interesting stuff around kind of acting our way into particular states, and it's been particularly interesting to see how we can switch on kind of parasympathetic responses with a few of these gestures. And that's really the intention here. It's to just make sure that you take a moment to let yourself kind of feel a bit open, because this strange kind of scenario of meeting clients over screens for long periods of time, a lot of the kind of techniques that you've automatically developed to kind of keep yourself calm, I think, disappear. So I think it's just about making this stuff conscious again, briefly, as you kind of get used to using video conferencing again. Folks, I'm going to push on because we're closer to the end than not. I'm just going to mute you all. So just a few other bits and pieces. In terms of sound, I think this is a very natural response that happens. I've been certainly at tons of meetings in kind of tech land where a bunch of people pile into one room and a bunch of people pile into another room, and then they scream at each other. And I think it even happens in terms of one-to-ones when you have a screen in front of you. They kind of have this tendency to kind of scream at the monitor. And it's especially important for us as clinicians to kind of watch our voice tone, keep the voice tone kind of as close to a natural cadence as we possibly can. It's one of the reasons I hooked up my earphones to meet with you today, because I've certainly found that using my earphones helps me kind of keep the kind of natural kind of rhythms of my voice as much as possible. So to just encourage you to think about kind of doing the same. Oh, sorry about this. But just think about the value of earphones. And even if you're not using earphones, just watch that tendency to shout. In terms of privacy, look, there's a whole bunch of issues raised here, and Myrn's going to talk a bit more fully about privacy tomorrow. But some of the key things to keep in mind when we're thinking about privacy is, can other people hear the call, hear the meeting around your patient? So certainly earphones are one way for solving some of that, because at least you and your comments are only audible to the client themselves. And getting your client to use earphones in one way can help them speak lower, but if they've got both your ears connected to earphones, there is the risk that they're talking more loudly than they imagine. So Myrn will talk tomorrow about a couple of kind of neat ideas, like, for example, playing some ambient sound near the door, maybe talking and negotiating with other people in your environment to make sure you've got some privacy. But these are kind of key things to think about. We are ultimately arriving and doing private work in people's homes. You'll also want to think about your own privacy. So there's a number of concerns and things that people have raised. For example, calling into meetings, does that give clients does that give patients our phone numbers or our email addresses? So with many of the video conferencing apps, there are ways and means and workarounds to this. For example, lots of us will be using Zoom. And if you don't want to share an email address with a patient, you can always phone them up before you start the meeting and just call out the meeting ID and the password to the client over the phone. And then they can come straight into the call after this. Just pushing on with this as well. The last area to mention to you is just to talk a bit about eye contact. Some of you will have noticed something I've been doing very deliberately through this meeting. I have not been eyeballing you all. I could have kind of done that thing that lots of us kind of naturally do, where we kind of sit here and we just stare at the screen. But actually, this is not how we kind of relate to patients in the real world. In actual fact, we do a lot of kind of taking the intensity off and looking around. And even meeting you today, it's kind of helped me kind of regulate myself, not just to be staring at the screen, but to kind of to look away and to kind of think. And again, mirror those normal kind of conventions of conversation, because what we're attempting to do all the way across video conferencing is mirror what a real conversation looks and feels like. So that's it in terms of the kind of key messages I want to put across. Thinking about privacy, the picture, posture, eye contact, technology, and sound. Some of you will have seen a PDF I sent out that's just a couple of pages that summarizes this stuff, and I'll send it out again today to everybody who's called in. But as we wrap, just to remember, this is our goal. Our goal is to make your call feel as much like a real conversation as possible. And that there's a few kind of, comments to make on the way out. The first is, you might need to fake being comfortable for the sake of your patient. So even if you're feeling deeply uncomfortable, and lots of you will be, I think as you're getting to this, try to act as if this is normal for you, because it will help it feel normal for your client. At the same time, I think it's important to normalize the weirdness of the whole thing. With my own patients who have been kind of crossing the line and doing this video conferencing stuff over the past short time, we've kind of acknowledged it's kind of weird. I'd say the rule of thumb is it takes about 10 or 15 minutes to kind of get up and running. And without fail, the meetings I've done over the last 2 weeks, the feedback has been at the end of that call, I actually forgot that we were doing by video conferencing in the first place. The third thing just to mention here is to be ready to switch to your telephone in a heartbeat. I think this is the biggest backup plan. Firstly, this won't work for some of your patients. You'll try it and they'll hate it. They'll get frozen by it all. They'll feel overwhelmed. So if that's happening, you just make your clinical judgment and just jump off the video call and get onto the phone. But also, like I said, the technology is going to let us down sometimes. So it's great to have the telephone option available. This is for you to think about in terms of where you should sequence use of video conferencing in your team. Some of us are early adapters when it comes to tech. If that's you, dive in. And if you're not an early adapter, if you're someone who tends to kind of hang back with this stuff, maybe it's a good idea to let some of your teammates in first, and then you can kind of follow. Regardless of whether you're early adapter or not, I think you should do some practice with your colleagues. And the very last, I think this is magic if you do this, last tip, is make sure that you do this 10 or 15 minute kind of pre-call with your patients. So you particularly schedule a slot of time to get on board, to make contact by video conferencing, to coach some of the very things we've been talking about today, and for you both just to feel kind of comfortable. And then you call back a little bit later and you do your meeting, but you've kind of gotten through some of the really strange and weird stuff that can happen. So we're at time.